is Dr. Bidard from Institut Curie on fulvestrant-palbociclib versus continuing AI palbociclib upon detection of circulating ESR1 mutation in hormone receptor positive, HER2 negative metastatic breast cancer patients, results of PADA-1, a UCBG-GINECO randomized phase 3 trial.
Good morning, thank you very much, and thank you for having selected our abstract for an oral presentation today. So PADA-1, it's the first of its kind trial. So it is a switch study in which we investigated fulvestrant and palbociclib versus continuing AI and palbociclib upon the detection of circulating ESR1 mutation in HR plus HER2 negative metastatic breast cancer patients. As a background, I'd like to remind you that ESR1 mutation restores ligand-independent ER activity in ER-positive metastatic breast cancer. These mutations drive resistance of ER metastatic breast cancer to AI, but retain sensitivity to AI degradation by thirds. These mutations are detectable in blood by cell-free circulating DNA analysis. And I will refer to this ESR1 mutation detected in blood as of BESR1 mutation, such as in BTMB, for example. BESR1 mutations are rare at metastatic breast cancer diagnosis, but very frequent at progression and the first-line AI-based therapy. We know these mutations predict resistance to AI, but not to fulvestrant nor to palbociclib. The concept of PADA-1 is, let's say, quite original. The idea is to prevent or delay tumor progression in patients receiving first-line AI palbociclib treatment by targeting ESR1 mutation with a switch to fulvestrant as soon BESR1 mutation becomes detectable while maintaining CDK4/6 inhibition. So again, it is a switch study. It is not a proper first-line study. It is not a second-line study after disease progression. It is first-line switch study during the first line. This is our study design. So main inclusion criteria were a patient with good general condition, HR plus HER2 negative metastatic breast cancer, and this cancer had to be AI sensitive, which means no relapse under adjuvant AI or within the 2 months after AI discontinuation in the adjuvant setting. Of course, no visceral crisis. So these patients were included in the first step of PADA-1, which consisted in a standard of care AI and palbociclib therapy. Premenopausal women received also LHH agonist. So as part of PADA-1, we screened for BESR1 mutation at inclusion 1 month and then every 2 months during all the treatments. The result of these BESR1 mutation detection and a bridge study to NGS have been reported earlier today at this conference. Then, in step 2, so patients with a rising BESR1 mutation and, very importantly, no synchronous disease progression. So these patients have just a signal in their blood, a molecular signal in their blood. So we're randomized between AI and palbociclib versus fulvestrant and palbociclib, the experimental arm. In a third step, we offered an optional crossover to fulvestrant and palbociclib to patients who were initially randomized in the AI and palbociclib arm. Endpoints. We had 2 primary endpoints. A safety primary endpoint, which has been reported earlier at this conference as a poster. We spent no p-value on this safety analysis description. The investigator assessed progression-free survival in step 2. So you compare the PFS, so measure the PFS from randomization to disease progression in both arms. This was an event-driven analysis, and 120 PFS events were needed in this step to trigger the primary analysis. This is a flowchart of PADA-1. As of the database lock cutoff July 31st, we had a median follow-up of 34.5 months. 1,017 patients were included in the first step and treated with AI and palbociclib. Of them, 279 patients had a rising BESR1 mutation detected during their first-line treatment with AI and palbociclib. Of them, 172 patients with a rising BESR1 mutation and no synchronous disease progression were randomized between the standard arm, so keeping on with the same treatment, we dismiss the molecular signal in their blood, or a switch to fulvestrant and palbociclib, so taking into account this molecular information, this rising resistance mutation in their blood. Characteristics of randomized patients, so in step 2. These patients had a median age of 60 years in the AI plus PAL group, 62 in the fulvestrant plus palbociclib group. So characteristics were well balanced between the two arms. Of note, patient before randomization spent a median time in step 1 that was 14 months. So moving to the primary analysis results, again, so PFS in the second step of Padawan after randomization in patients with a BESR1 mutation detected during their treatment with AI and palbociclib. So the median follow-up in step 2 was 26 months, and as you can see here, patients who were randomized to the standard of care arm, which is keeping on with the same treatment, AI and palbociclib, had a median PFS of 5.7 months. In the experimental arm, we observed more than a doubling of the median PFS with the early introduction of fulvestrant combined with maintenance of palbociclib. So 11.9 months. The stratified hazard ratio was 0.61 and the p-value was 0.005. Of note, the absolute difference in median PFS is 6.2 months, which is very relevant from a clinical perspective. In terms of subgroup analysis, these subgroup analyses are displayed here. We found no significant interaction within the different subgroup of patients, including the stratification factors. In terms of toxicity, I'd like to remind you that these patients were already on AI and palbociclib, so some of them could have been dose reduced during the step 1, but upon randomization, so at a later time, so when they have this BESR1 mutation rising in their blood, so they were kept at the same dose of palbociclib. So we had very few dose reduction in the second step, and the grade 3/4 adverse event we observed were mostly neutropenia, as you can see, and were equally balanced between the two arms. So, as expected, we have no new safety signal. Then, a very important assessment is what do we get if patients receive fulvestrant and palbociclib after progression? That is our standard practice. Usually, we don't look for ESR1 mutation. We don't switch patients with this rising BESR1 mutation, and we wait until they have a resist tumor progression. So how would fulvestrant and palbociclib, so the treatment that was offered here in this experimental arm, how would behave this therapy when given after disease progression? And would the PFS achieved in this patient would catch the benefit observed with the earlier use of fulvestrant? And so we had a median PFS in crossover cohort of 3.5 months. Of course, not all patients were included and were participated to this crossover because it was an optional crossover cohort, as patients may have visceral crisis at time of progression, for example, and could have not been eligible for a second-line fulvestrant-based therapy. So, to conclude, Padawan, it's a first clinical trial, again, first of its kind, maybe not the last, to demonstrate the clinical utility of BESR1 mutation monitoring. It allows to optimize, to personalize the endocrine therapy partner of CDK4/6 inhibitors in first line. Upon BESR1 mutation detection, a median PFS was doubled with the switch from AI to fulvestrant, both combined with palbociclib. We had no new safety signal. The observed clinical benefits might be underpinned by a lower burden of ESR1 mutant tumor cells, so a lower number of ESR1 mutated tumor cells at time of early fulvestrant initiation. And that clinical benefit is not caught up by standard fulvestrant-based second-line therapy, as illustrated by our crossover cohort, but also as illustrated by PFS obtained in the EMERALD trial that has been reported earlier at this meeting. We believe that this clinical benefit might also justify the implementation of the Padawan treatment strategy as a valid option in routine care. At a higher level, we also believe that monitoring the rise of resistance-associated mutations could open up new opportunities for cancer therapy with new agents, such as next-generation SERDs in metastatic breast cancer, and also in other clinical settings and beyond the ESR1 mutation. I'd like to acknowledge patients, their families, and many investigators, genetic platform at Institut Curie and Institut Universitaire du Cancer de Toulouse, study project manager Cynthia Wong-Bartlett, Maria Koller, and the trial was funded by Pfizer. Thank you very much.
Thank you, Dr. Bidard, for a really interesting presentation. Microphone one.
John Cole from New Orleans. What was the average time between when patients enrolled and when they were then randomized?
Yes, it's 14 months.
There's a series of questions, and I think the most compelling sort of way of thinking about this is really around the endpoint. So if you want to argue that changing on the basis of a biomarker prior to radiographic progression, then the question is, are you better switching early with either progression-free or, one might argue, overall survival, or is it progression-free survival on the unswitched plus the progression-free survival as you showed later? So is the comparison really 11.9 versus 9.2? Or should we be looking at overall survival? And just comment on lead time bias and these sorts of methodologic issues.
Well, in terms of lead time bias, so both are assessed. So the start point is the same. So the time of randomization. So there, I would not call it a lead time bias. When it comes to adding PFS, so PFS1 plus PFS2, adding the median PFS, yes, we still have a benefit. Are we allowed to do it from a statistical perspective? Not always. Remember that when you have a disease progression, sometimes it will also take about for 1 month for the patient to be switched to the next therapy, because patients are not starting the second line right after the scan, for example. So it's very difficult to strictly add, but we had to measure it. That was the purpose of the crossover. Without a crossover, I think that our results could be really challenged by the question that are asked here. But here we are providing some sense of what could be the PFS with Fulvestrant-palbociclib in second line. And also, I think the data of EMERALD are very compelling in terms of PFS that could be achieved, with Fulvestrant. It was single agent in EMERALD, but here it's in our trial, it's palbo after palbo, but after progression, maybe the efficacy of palbo is limited. So, however, we cannot add strictly these 2 million PFS, but still the magnitude of the benefit is, I think, much higher than what we can get with the second line standard treatment.
Thank you. Microphone.
Excellent presentation. Congratulations. Was there any association with the fraction of ESR1 mutation in blood? You keep mentioning rising, but it was really just the appearance. And also, what happened, I'm guessing you're going to present that at a later time, to the ESR1 fraction with change of therapy or treatment on progression?
Yes, thank you for this question. So then it relates to further analysis about the kinetics of ESR1 and the type of mutation and what is the kinetics after randomization, yes. So all this work is planned and will be ongoing. I'm sorry not to have the answer yet, but definitely that is of interest, mutant allelic fraction, kinetics, patient characteristics, mutation types. So next Congress.
Can we assume that there's a group of patients that has a different kind of resistance to the mechanism, and therefore when they are being switched, as part of the group that just was treated on a progression, you're seeing a slightly different group than the group that you're specifically selecting for an rising ESR expression?
Yes, so this trial focused on ESR1 mutations. So, but yes, we acknowledge that when we see an ESR1 mutation, a tumor cell might have acquired also other mechanism of resistance. But what is interesting is fulvestrant is not a targeted therapy only targeting ESR1 mutated tumor cells. We are using it in routine practice in the second line, whatever the mechanism of resistance. So we could expect some efficacy also on other mechanisms of resistance, if any, that could be present on top of ESR1 mutation in our patients.
No, but what I'm saying is when you're switching, you're selecting for that particular mechanism. When you're treating a progression, you're treating all progressing events.
So in our study, the crossover part, so it was patients that were randomized and they had this ESR1 mutation. So I would think they have the same kind of molecular resistance mechanisms that in the experimental arm.
Okay, thank you. I think we need to move to the next presentation.